So what we're going to do now is have our final speaker for the morning, who's Andrew Kennedy. He's going to speak about embolic therapies in the treatment of NET. He's the physician-in-chief of radiation oncology at the Sarah Cannon Cancer Center, went to medical school in Loma Linda, trained at University of North Carolina in Chapel Hill, and then subsequently has been practicing at Sarah Cannon in radiation oncology, and an expert in embolization techniques, and will be talking to us about that subject. After he finishes, we're going to have all the speakers come up to the front, and we'll answer questions from all of you. Thank you.
Terrific. Thank you very much. I appreciate you inviting me. First, want to acknowledge that it's nice to be here, and it's been a few years since I've been to this meeting. It's always a terrific environment, and it's a pleasure meeting patients. And many of you, I know because I see patients, primarily neuroendocrine patients, that have come from somewhere else, could probably give a lot of these lectures. Brief disclosure on some research funding our institution has. And I just want to highlight some things that most of you know, and those of us who see a lot of neuroendocrine patients know that when our patients come in, our nurses get a good education. They'll just start asking patients about various things because you are probably the most informed group of patients we deal with. But why liver-directed treatment? We just heard an amazing talk on replacing organs, and boy, if we had a lot more organs, that would be a great approach. But the reason that a radiation oncologist or an interventional radiologist, which I'm not, but I work with, would see patients with predominant liver disease is what I've highlighted in blue. And it's really the main reason that most patients wind up succumbing to their disease. So trying to prevent the progression of disease in the liver is a very important goal. Now, there we go. The two main types of dealing with liver from a non-surgical standpoint is to use the arteries that go into the liver against the tumors. Many of you may know that the liver has two blood supplies, one that comes from the gut and predominantly goes to normal liver, and then the hepatic artery system, which is a separate and much smaller system that predominantly feeds metastasis to the liver. And that could be metastasis from any of the neuroendocrine tumors. Now, the main type in the United States for most of the last 50 years has been using a particle or a sphere, and you can see in this diagram it's the two big spheres on the right side of the slide, and they are inert, meaning there's no chemotherapy in them, there's no radiation in them, and their main purpose is to block blood flow to the tumor, starve it, kill it that way. And then there's a relatively newer, I would say that, but the godfather of this is here, Dr. Warner. I've had the great pleasure of meeting and working with him over the years. Some of the first patients he treated in the early 1960s were neuroendocrine patients, and he used radioactive isotopes on smaller microspheres. And back in the days when there weren't manufacturers of this, you had to have creative physicians to come up with industry to make it for you. Now there are commercial products, and using radioactive microspheres, which I'm going to spend a little more time on this morning because it's less known, has been a very successful treatment approach. So the two approaches using the arteries is to deliver a microparticle that will block blood flow, or the other approach is to use the arteries to deliver the payload right into the tumor, which is the radioactive component. So we often talk about the non-radioactive as TACE or TAE, and that stands for transarterial embolization or transarterial chemoembolization. And that is delivering a payload in the artery somewhat upstream from the tumor itself. Let's see if I can get this next one to come up. So this is a hepatic artery, and as it flows to the tumor, as you see off to the right side of the slide, the non-radioactive ones are larger particles, and they block the blood flow somewhat upstream from the tumor, and you starve it and kill it that way. However, if we're using radioactive particles, they've been engineered or used as a much smaller particle that will get into the tumor itself, because the advantage of this type of radiation is it doesn't go very far. It only goes about 1/4 of an inch from where it impacts. So it has to be in the tumor. And that's a good thing because it gives a lot of dose in the tumor, but it's also a good thing because the radiation doesn't spread throughout the rest of the liver. So as a radiation oncologist, I use external beam radiation very often to treat cancers. And the unfortunate thing is that the beam on its way into the tumor delivers some of its radiation in normal tissue, then it hits the tumor, but then it goes right out through the body and again delivers radiation to other organs you don't want it to on its way out of the body. This is a different form of radiation called brachytherapy, which is implanting it, and therefore that short distance that it goes is its main advantage to protecting liver. So this cartoon is to show the two things that can happen when we're trying to deliver a payload into the tumor itself. So this diagram is specific to the smaller spheres, the radioactive spheres. Now you can see in the panel marked A, there is some green that's supposed to be a cloud of killing radiation. And then there's a spot in the tumor that doesn't have any cloud. And that is because not enough spheres were deposited in that area. And that can be from a variety of reasons. Either we didn't give enough, which is unusual because we give 15 to 18 million spheres, or the blood flow was such that it could have temporarily spasmed and prevented it from going there, or there could be some other local phenomenon that we can't control. But panel B is what we're trying for, and this is sometimes referred to as the bystander effect, where you get just enough microparticles with radiation close enough to each other that there's overlapping of the radiation clouds. And again, that's something that we are guessing at. It's part of the art of medicine. We're trying to deliver enough radiation to that tumor to get panel B, but not so many spheres that they're going into the normal liver. There's somewhat of a misnaming of radioembolization. Before we knew all the ways that we were killing tumor with radiation, we called it that. But in fact, it doesn't kill by embolizing or blocking blood flow. And this is one of several papers showing that the resulting injury is radiation in the tumor and not what we call stasis or causing lack of flow into the tumor. That's very important because radiation depends on oxygen to be effective. If you don't have oxygen in that tumor, if you've blocked it, the radiation will be only a fraction as effective as it could be. There is a minimal size of tumor in the liver for which this type of approach with radioactive particle is effective. So to have that differentiation between a microparticle going to tumor and going to normal liver requires that the tumor be a certain size, and that's usually something that will show up on a CT scan or an MRI that's done of the abdomen. If it's smaller than that, and the reason to bring this up is it's often a comment that, well, my surgeon removed some of the tumors, but there's microscopic disease there, so can you give me those radioactive particles, or can you give me the non-radioactive particles to kill it? And the answer is generally no, because then we don't have that selection where the blood flow is going to the tumor only. So a tumor has to be a certain size, usually about 3 millimeters, before it gets its own blood supply that we can exploit. There is a price to pay with these smaller particles with radiation implanting into the tumor. So this cartoon is to show tumor in the bottom right part, and if we were to perfectly implant the rim of the tumor, which has the active disease, the cloud isn't going to stop at the border of normal liver and tumor. It's actually going to extend about 3 millimeters. So there's a little bit of a rim around each of the tumors that's at risk for having radiation injury. And we take that into account when we're determining eligibility of the patient to have radiation in this form. This is a slide of a patient with a neuroendocrine tumor that received radioactive microspheres, and the arrows are pointing to all the little black spots you see there. And then there's a line there that I've drawn showing normal liver. So this is interesting on a couple of aspects. For radiation oncologists, it shows a very short distance between full radiation and death of tumor cells and then normal liver. And that distance can't be replicated with any external beam. That's a function of putting radiation into a tumor, and we call this penumbra, where that cloud overshoot is. So it's an aspect unique to radiation internally that's different from external radiation. And this particular patient had an extraordinary response, but Unfortunately, the liver reserve was insufficient and wound up having a liver transplant. That's how we have these images, and was alive and well at 5 years was the last I heard about. So as you've seen, and many of you have seen your own scans, there are a variety of distributions of tumors in the liver. There can be some solitary ones and multiple ones. And this is a typical presentation for patients who are being considered for an arterial or embolic approach, because they hopefully have seen a surgeon already adept at transplantation and resection, and they were judged to not be a surgical candidate, but we want to control the hepatic disease. So part of what we do when we're planning either approach, whether the bland or the non-radioactive approach or the radioactive approach, is to determine how much tumor is present in the liver and how do we get to it. And that's done by our interventional colleagues who do injections in the liver and map it out. But there are some pros and cons to which of these two internal approaches to take. So think of it as there's two cars and you're going to go to the grocery store. Both cars will get you there, but there are some pros and cons to which vehicle you take depending on the individual circumstance of the road. And so with radioembolization, or using the radioactive side of things, there are some patients for which it is probably the better approach compared to the embolization. And conversely, there are patients for which it would not be wise to use the radiation. And I'm going to show you some scientific rationale for that in a moment, but I just wanted to paint the picture. These are not interchangeable for some patients, but for more than half of the patients, I would say either of these approaches would be perfectly fine, and there's data to support both in those patients. Well, typically, patients that considered for liver arterial treatment have most of their disease in the liver. They are often symptomatic with some form of cancer-related issue, and very commonly it's pain, but it can be secretion of the hormones. One of the disadvantages to the non-radioactive approach is something called post-embolization syndrome. And we're not quite sure exactly what causes that, but about 40% of patients that get the non-radiation approach, the TACE and the TAE, about 40% of those patients will need to spend a night or two in the hospital with pain relief because it's so painful and causes nausea and vomiting. And we think we have some reasons for that. There's a lack of blood supply that's abrupt. There are some other factors. But in other patients, we don't know why. And why is it that internal radiation with the microspheres doesn't cause post-embolization syndrome? So I'll just tell you, we don't really know. But for some patients, we would then choose the radioactive approach if we thought they were at high risk for post-embolization syndrome. For the internal radiation approach, the vast majority of patients go home the same day. About 99% of the patients go home that day. And they might need to take some pain medicine or anti-nausea medicine for a couple of days. The risk factors are very low for serious complications, and those would be a gastric or duodenal ulcer, and then very rarely radiation-induced liver disease. So a quick list of things to consider are on the pros for using the radioactive microspheres. And I should mention that back when Dr. Warner started, he was the only person in the world doing it. And then about 20 years later, there were 5 to 6 centers. And now there are 380 centers in the United States that offer that. So it's not as it was in the older days that you had to seek out a center of excellence that only did this. So both of these options should be available in every metropolitan area in the US. But on the pro side, aggressively treating the liver can lead to better survival. They're usually hypervascular tumors. And in patients that are neuroendocrine specific, they don't have some of the underlying health issues that someone with, let's say, hepatitis has had and developed hepatocellular cancer. On the downside, however, there are often, when we see patients, too many tumors to count, so there's a higher risk of injuring normal liver. There are, for many centers around the US, just a comfort level with using the non-radioactive approach, and they do extremely well at it, and they're well published in it. And then there's different chemotherapy agents that can be used with these agents now called drug-eluting beads, which can contain some chemotherapy instead of just blocking the oxygen and blood flow. But as I'll show you in a few moments, there is an amazing lack of clarity regarding research data. Now, not surprising to this audience because you live it every day. There's a lot of art, there's a lot of expertise that goes into selecting treatments for neuroendocrine patients. And unfortunately, that's a continuing trend. The prospective randomized trial, and particularly you heard about that earlier today from our surgical colleagues, is not a practical thing to do in some disease types for which there is great heterogeneity. You know, there's no two tumors are the same almost. And there's also, let's say, a lack of network of expert clinicians to enroll those patients. So part of the issue on what to do with liver-dominant disease from neuroendocrine patients was a conference that I was a member of in 2012. And what I wanted to paint the picture here is this was a gathering of experts, many of whom are speaking at this meeting. And I was part of the panel specifically looking at arterial delivery of treatment in the liver for neuroendocrine disease. And we were tasked with multiple questions to answer, but part of what this publication pooled is the type of patients that got certain treatments. So for yttrium-90 or radioembolization, the vast majority of patients were carcinoid patients or islet cell or pancreatic tumor patients. And to further pile on to some of what my fellow speakers have said is liver metastases from neuroendocrine tumors is very different than liver metastases from colon cancer, breast cancer, lung cancer. And unfortunately, too many patients don't get the expert opinion they need in this group of diseases. And when they come to those of us who have an interest in this disease, as you heard from our transplant team, they already have passed many opportunities up. So this is a graph that I try to show my colleagues in general surgery and in medical practice that does oncology, is that unlike adenocarcinomas, we have a real chance at helping patients with liver-dominant disease from neuroendocrine tumor from a variety of techniques, as you've heard this morning. And if we just put this line here in the middle, liver-dominant disease is somewhere intermediary, so it is a serious condition. One of the weaknesses of a more recent treatment, radioembolization, is that we don't have as mature data for overall survival. So what I'm showing here from our manuscript is that unlike even PRRT, which has overall survival, median survival publications, we don't have that for yttrium-90 patients, and I'm going to show you some of that data here in a moment. So this is a table from the manuscript from the entire group, and what I wanted to highlight here is what we've added here is the addition of selective internal radiation therapy, or yttrium-90, radioembolization, microsphere therapy, whatever you want to call it. And this is a formal step forward or endorsement of multiple worldwide organizations that it appears a reasonable option for patients with neuroendocrine tumors instead of or in addition to TACE and bland embolization. So this graph here, table, is to show that there are about 436 patients in the literature as of a year and a half ago that sole publication was the use of the radioactive microspheres in neuroendocrine patients. Not a lot of patients in the literature. To compare that to what had been the de facto standard and the only other thing, there were about 640 patients in the literature from what we would consider good publications, meaning they were peer-reviewed publications, that there were basic information that the authors put forward to help us analyze whether the report was valuable. So the TACE and TAE information, although it's been around a lot longer, it's been in most institutions, it isn't exactly held up as a model for publication either. So how does a patient decide, or how does the team decide which of these to use if the decision is that liver-directed therapy is important and arterial approach is what we prefer? So we published about 2 years ago our consensus from that meeting just for that question. And what we came up with was not just a typical overall survival and disease-free survival, and some of the other parameters that we're used to pulling out, was we did do that. But the committee thought it was helpful to add in some other things that might be helpful, such as cost of the treatment, toxicities or side effects. If you give a great treatment, but the patient spends every weekend in the hospital for a month, is that something we should put into the equation in choosing? So we used a grade score and the NCI level of evidence score. So balance of toxicity and benefit, quality of the evidence that we were evaluating, the values and preferences of patients, and that's something very unique in a publication of this type, and then the cost. This was not a cost effectiveness manuscript, meaning if you put in this much money, you get this much benefit, but we wanted to put in costs as part of the decision tree. And I'll just cut to the chase here. What we came up with, the 5 questions that we were asked to specifically answer were that neither of the 2 types of microsphere approaches was known to be superior to the other in overall survival or outcome. And we thought there was moderately strong data for that. That there were a variety of other questions thrown in there about response rate and tumor types, et cetera, and there was really not good information for us to draw on. And on the committee, we had experts in every type of treatment, and we had institutional unpublished data to look at as well. So what I've boxed here, number 5, is that we did feel that our brethren in the European Neuroendocrine Tumor Society, who was on the committee, we adopted their guidelines, and they agreed, as we agreed, that putting the radioactive microsphere treatment alongside an option for TACE was reasonable. So we borrowed their graph, and we divided up 3 levels of liver involvement by tumor, either a few simple liver metastases, or a more complex pattern in both lobes, or a diffuse pattern, and then what were recommendations for that. And what I just want to highlight is we focused on just a few publications that were prospective, meaning the intent of that study was to test radiation in the liver, and it was prospectively gathered, so it's a little more scientifically robust. And the grades were on a scale of A, B, C. They were Bs for the most part. So reasonably good balance of side effects and cost. And on the NCI side, was it a robust scientific paper? Well, it's 2A out of a scale of 1, 2, and 3. So just for reference, I'm going to mention here that the guidelines that we added on to, we weren't creating new ones, or the European Neuroendocrine Tumor Society, and this graph looks very similar since we, with their permission, borrowed it and added to it. And I just want to comment that whether you're in the single area, whether you, where you could add yttrium 90, so for some patients in that category, and I should emphasize this, in our multidisciplinary tumor group, we start off with what is the gold standard, and that would be surgical resection. Then we go on to the next best thing. Is it something potentially curative down the road, such as transplant? And if those questions are answered and we get to no, then a liver-directed approach is indicated. That's when we get to this table. So whether you have a simple unilobar or one side of your liver disease, or whether in the next category you had both lobes involved, using internal radiation was considered reasonable and equivalent to using the non-radioactive microspheres. And then even in the diffuse liver metastases, there were some patients that would benefit from that, although the danger increases, as you've heard, with liver reserve, whether that's from a surgery or whether that's from an embolic treatment. So our conclusions, and which have now been published, is that there's moderate quality of information to use in guiding your team on which of these 2 products to use, and that the quality and strength of the available reports doesn't allow us to fine-tune this into who should get what exactly. That's really the medical expertise of your team. There could be some advantages of using the radioactive approach in some patients because there's fewer of them that will have to be admitted for post-embolization pain. And I should mention that post-embolization pain doesn't have any impact on overall success, but as we're balancing between what is a, quotes, better approach, not being in the hospital getting pain medicines for 2 days would be considered an important component, but it isn't that it's one is more effective than the other based on the lack of pain. And then currently, as I've mentioned, Centers that offer both of these treatments can feel very comfortable interchanging them. Centers that only offer one, and this would be for most centers that prior to about 2005, really should look into acquiring that technology as well. I should comment on the safety of an internal radiation approach if patients have received prior radiation. And it used to be that for many of us, we had to refer our patients to Europe for PRRT. They would then come back, and we'd eventually be directing treatment to their liver. And the issue here is previous radiation to tissues causes some injury. Could we safely then add radiation again to the liver safely, an overlap, so to speak? And as you may recall, there's a certain percentage of liver that needs to be pristine and functioning well for the patient to survive. So we, as radiation oncologists, adopted what our surgical colleagues use for that volume. And in a preliminary report some years ago, we showed it was safe in a small number of patients to do that. And then subsequently, our German colleagues have published on 23 additional patients who got PRRT and then got internal radiation. And this isn't too surprising, because we now know from very sophisticated publications on external beam to the liver using stereotactic body radiotherapy, or SBRT, which is the fastest growing aspect of radiation in the United States, that we're faced with this same question. So patients that were treated with SBRT now are coming for yttrium-90 treatment, and the data is showing that it is very likely to be similar, that it is safe as long as you're measuring those two types of radiation and are selecting patients based on how much liver is preserved. It is safe to give both. And I will yield the rest of my time for the committee. Thank you.
Thank you very much.